Hey, everybody, let's get started. Thanks for joining. I'm Cameron Mahle. I'm the medical director in New York for Soul Mental Health, and I'm a psychiatrist. And this is a advanced psychopharm for the primary care physician when Lexapro doesn't do the trick. So just some kind of extra steps you can take that I think are applicable to the primary care setting when SSRIs are just not cutting it. Here's a little overview of some of our values and missions at Soul. And we'll start with some psych dogma, which happens to be in the primary care wheelhouse, so something you're probably very familiar with and good at doing. We always think about the fundamentals of medicine that we're all rooted in, and that should always be top of mind when we're treating psychiatric conditions. So in other words, Psycho 101 is always to do what you're already doing, which is to consider, medical etiologies and substance-induced etiologies before we assume it's a primary psychiatric condition, right? So we have to rule those out first. Depression, anxiety, panic, psychosis, mania, all the whole spectrum can really be mimicked by various underlying medical conditions, including substances. And so it's really important that we make sure that those are not the root cause. Otherwise, we're going to be chasing our tails and not doing the patient any benefit. And so picking a psychotropic is really not top of mind if that's what's going on. We really need to treat the root condition in order to get sustainable relief. Now, maybe there's some role for psychotropics in the meantime, but really the sustainable ultimate resolution here is going to be identifying that medical etiology or that substance and mitigating that first, and that's going to lead to resolution. So primary psychiatric conditions versus medical / substance-induced psychiatric symptoms. I mean, there's a lot of them that can mimic psychiatric disorders, right? We consider these especially when they are, when we have a psychiatric condition seemingly that presents in a way that is particularly suspicious for a medical etiology, right? And so some examples would be panic disorder with diarrhea, tachycardia, arrhythmia, insomnia. Was I muted before, or were you hearing this?
We can hear you.
Oh, you can hear me. Okay. It said I was muted. All right. So some classic examples of particular examples of what I just said about, psychiatric conditions that can mimic, or I'm sorry, medical etiologists can mimic psychiatric conditions, but have some suspicious components that make us think about substances or medical etiologies. So that would be like, for instance, a panic disorder or anxiety that also presents with diarrhea, tachycardia, arrhythmias, insomnias, right? And that sort of looks like hyperthyroidism. So we're going to make sure that it's not hyperthyroidism before we get carried away with diagnosing panic disorder or generalized anxiety disorder. So we'll order, a TSH, a free T4, make sure that those are in order. If we find out that that's the culprit, then obviously we're going to be treating hyperthyroidism and investigating that further in order to get a sustainable resolution of those psychiatric symptoms. And there's no role for psychotropic, really, at least not long term, if that's the root cause. Another common example would be perhaps depression, fatigue, cognitive decline. The patient's vegetarian, right? We need to be considering B12 deficiency, so we'll get a B12 level and make sure that that's not the root cause. If a patient's manic, got dilated pupils, maybe they have a history of an ADHD diagnosis, an Adderall prescription, you check iStop, the PMP search, they have an Adderall prescription, maybe it's even suspicious on the PMP search, maybe they're doctor shopping, something like that. You got to consider that they are abusing some sort of stimulant, and that could be the Adderall that they're prescribed, that could be It could be methamphetamine, could be any stimulant that they're abusing. It's going to look like mania, and almost be indistinguishable except for, you know, catching it on a Utox, perhaps some other aspects of it as well. I mean, I don't know that mania typically presents with dilated pupils, but you know, I think the major investigation here is, you know, making sure there's no substances in their system. And a hypomanic state or a manic state also could be mimicked by steroids, corticosteroids, right? So it's not that uncommon that you give somebody prednisone, which is fairly commonly prescribed for various things, right? And this can very frequently make a patient become manic. Seen it in the hospital, seen it as outpatient. It's you know, indistinguishable really, except for the fact that there's a history of them taking prednisone recently. And it's not that uncommon. And so we don't want to diagnose them with bipolar if this is induced by some corticosteroid, right? So, and they're notably, the fact that they've tolerated corticosteroids, prednisone in the past without this problem doesn't really mean that they won't develop in the future. So that's not really reassuring that it's not that. So, you know, we need to always consider that that's a possibility, even if they've tolerated prednisone before. And even in the garden variety, depression, anxiety, you know, it's still a good idea at some point, even if it doesn't, you know, look suspicious for a medical etiology or a substance, to just get some lab workup at a minimum, just to establish baseline values, right? Because if we are going to start a psychotropic, we probably do want some baseline values for some of these things. And sometimes you'll catch something that will actually, you know, even though maybe it wasn't reeking of some sort of medical etiology or substance, it actually still catches something, or at least something further to investigate. And so what are the choice psych labs? Well, they're, you know, it's not limited to this, but these are kind of the go-tos. So obviously there's the TSH and the free T4. We'll always get a CMP, make sure their electrolytes are fine, LFTs are fine. Want to check CBC with diff. You know, they could be anemic, causing fatigue, maybe some depression. We an RPR because tertiary syphilis produces some pretty bizarre, psychotic, grandiose symptoms, and so we want to make sure they're fine with that. B12 level, which, as I just discussed, can lead to a bunch of psychiatric manifestations, but the root cause here is that. Folate, similar. Utox, obviously going to hopefully catch some substances. A pregnancy test is always important because if we're going to start a psychotropic, we definitely want to be able to counsel the patient about, and we still should do this even if they're not pregnant, about the teratogenicity of a lot of the psychotropics and the sort of risks, benefits, and alternatives associated with that, right? Vitamin D can lead to something that looks a little bit like depression, low energy, all of that. And a testosterone level, if relevant, because it also can produce depression, low energy, libido concerns, all of that. And so those are some classic choice psych labs that we kind of focus on. We'll also throw in some fasting lipids, hemoglobin A1C, maybe a INR, just to sort of, for good measure. I mean, a lot of the medicines, not a lot of them, but a fair amount of them have a predisposition for calling metabolic syndrome or weight gain, right? And so getting baseline values for those is also important so that we can see if a medicine that does have a proclivity for causing weight gain or metabolic syndrome, we have some baselines to compare it to, and we can kind of blame the medicine and maybe make a change if we need to, if that's proving to be a problem. If we can get an EKG, we always like to look at that and see what the QTC is, because some of the medications we use cause the QTC prolongation, right? Predisposition for torsades, all that. Not necessarily required for most of the medicines we use, and definitely not for this presentation, but just sort of an overview. Classically, Haldol and tricyclics are QTC prolonging drugs. There are a few more. Also, if we're going to put somebody on a stimulant, which is also something you might be dealing with ADHD, especially these days, and they have a history of some sort of heart disease and arrhythmia, getting cardiac clearance, or at least an EKG, and taking a look at that before starting a stimulant is always a good idea. And blood pressure readings are an important thing to have, especially if we're considering medications that cause hypertension or at least exacerbate it, like Effexor or venlafaxine. And so if they do present with high blood pressure, we're probably from, at baseline, right? We're probably not going to start a medicine that causes hypertension like Effexor. And then this is the CT head here. This is, again, pretty outside the scope here, but just for good measure. If somebody presents with a really new onset psychosis that is just atypical in presentation, for instance, that looks like schizophrenia, but they're 60 years old, schizophrenia usually presents in the 20s. That would be pretty bizarre. We might want to take an extra look at that before assuming it's schizophrenia. Maybe they have some sort of mass lesion pressing on a part of the brain that's causing schizophrenia-like psychotic symptoms. So we just want to make sure that we're not missing that in the atypical psychotic presentations as well. All right, so we've established, let's say, it's not a medical condition. There's no substance use issues here to explain it. So now what? So I'm going to describe 6 different scenarios where we might deviate from the SSRI class. I mean, as first line, SSRIs are a perfectly safe and effective choice, and it makes sense that it's a go-to medicine. But sometimes it doesn't do the trick, or there's some sort of presentation that just begs for a different antidepressant class. And we're going to go over some of these scenarios here where you might consider stepping outside of that SSRI, or at least considering an addition of a new drug that's different than an SSRI. So we'll talk about some scenarios like that. The first scenario is going to be where SSRIs just have proven to be not effective, right? And we need to consider an alternative class. And usually, when we'll get more into the weeds with this, but 2 failed trials of 2 different SSRIs is usually how we define a likelihood of just SSRIs are a failure for this particular patient. Scenario 2 is where the SSRI side effect profile indicates an alternative class. So sometimes patients just find SSRI side effects intolerable. Usually it's sexual side effects, which is the most common. And or there can be other things like activation or whatever, weight gain. Whether it's experience because they've actually tried it and they don't like it and they've experienced the side effect, or just part of your process of getting informed consent and counseling about the risks, benefits, and alternatives of SSRIs, they just don't want to sign up for it. They don't even want to try it, right? And that's totally valid. You want to make sure that you are aligned with your patient's values. Everybody's kind of got their own unique preferences here, and we need to respect that, because the medicine's not going to work if they're not on board with it. So it's very important that we're all on the same page with whatever medicine we do choose. So if they're not okay with the SSRI side effect profile, then we should move on. Scenario 3 is involving symptoms that indicate an alternative class. So sometimes a patient presents with depression, anxiety, whatever, some sort of psychiatric condition that we might be tempted to use an SSRI, and would maybe in normal circumstances be totally appropriate, and might still be appropriate and would work, but it is in such a way that that it just makes sense to go to an alternative class for various reasons, which we'll get into. Okay. Scenario 4 is when we can knock out either multiple symptoms of a particular psychiatric disorder with one drug by using its side effect profile to our advantage, or when we can knock out multiple conditions with one drug. And if that's the case, and if we can do that with an antidepressant that's not an SSRI, we should definitely consider that. That way we can kill two birds with one stone. And that is always preferable for various reasons. So some examples, and we'll get into the details of this as well, are when a patient presents perhaps with depression and ADHD. There's a kind of a go-to consideration for that. Perhaps anxiety and fibromyalgia, depression and IBS. We can usually try to address both of those with one drug, and it's usually an SSRI. Scenario 5, and this is probably the weakest one, but something to consider. Family history strongly indicates an alternative class. So if you have a very, we'll get into the details of this, but sometimes, you have a very strong family history that just demonstrates that a lot of close family members, similar genetic profile, obviously, just have not responded to SSRIs, or they've had very serious adverse reactions to them, right? So that might just sort of give us pause. Or the sort of more positive option in this category would be that we have several close family members that have just responded really encouragingly and significantly to a different type of antidepressant, and we might just kind of want to jump to that from the get-go. Scenario 6 is a partial response to an SSRI. You start somebody on Zoloft and you optimize the dose, and they've responded, right? They've gotten definitely some progress and they're happy about it. And you want to preserve that, but you've plateaued. You push the envelope on the max dose. And you just can't squeeze any more benefit out of it. And you're kind of in between a rock and a hard place because you don't want to give up on that progress that you've gotten. Patient has a positive, association with the medicine, is happy with it, but obviously not satisfied. It's not a stopping point. There's a lot more progress to be had. So what do you do in that situation? Do you toss it out and perhaps compromise the progress that you've gotten on Zoloft, or do you consider, or is there some other options maybe to consider to preserve that and maybe still get full remission by other strategies? And then we'll talk about that as well. So we'll go back. Scenario 1, this is the classic, just SSRIs don't work. And the way we sort of determine that is that we give them a fair shot. And what's a fair shot? Typically, that means we choose an SSRI and we bring it to a therapeutic dose. We can talk about what therapeutic doses are, but and we at least let them be on it for 4 to 8 weeks. Sometimes if we see a little bit of encouraging response in that time frame, we may extend that out to 10 to 12 weeks. But if you aren't seeing anything in regards to progress from around 4 weeks, 5 weeks, 6 weeks, that's usually not a very encouraging sign that there's going to be more or something really quite robust waiting for you, although it's possible. So 2 failed trials means that you've done this with 2 different SSRIs. You brought them to a therapeutic dose, you've given them a fair amount of time to work, and they just you've been underwhelmed, and so is the patient, right? Which is disappointing because we've spent a lot of time now, several months trying to make these SSRIs work. So let's not do it a third time. They have similar mechanisms of action. If 2 of them haven't worked, let's not keep trying that class. An example of a fair shot with an SSRI is here on the right side of the screen. So like week 1, you put somebody on Lexapro 10, totally normal starting dose. Some people will start with 5. Might as well get where we're going. If they're particularly sensitive to drugs in general, or that's sort of their personality, maybe you start with 5 just to make sure. But 10 milligrams, check in with them after a week. They're tolerating the medication okay, no side effects. Week 2, you bring them up to 20 milligrams. That's fine. Nice thing about Lexapro is you get to that max dose pretty quickly. So you can start to be at that therapeutic dose early on with it. And then, they're tolerating it fine, no benefits, which is no surprise by week 2, doesn't say anything. And then, now week 4, we're maybe hoping to start to see something that indicates that there's going to be a response, like even an inclination, a hint of something positive. If you're not seeing that, give it a little more time, but it's starting to be a harbinger of a non-response, right? So at week 4, we evaluate, there's still no benefit on 20 milligrams. They're still tolerating it well, so we'll give it a little more time. Week 6, week 7, evaluate, still no benefit. All right, I think we need to call it quits, throw in the towel, and that is a failed trial of Lexapro. Now, obviously, you want to maybe consider doing that again, but oh, I have a question. What anticipatory guidance do you give patients during this titration time? Are you checking in via phone call or portal chat? How do you keep their spirits up? So, definitely you want to lay out kind of the timeline, right? And that you wouldn't expect anything in the realm of benefits for those first several weeks. And that's no reason to be discouraged. It's mostly about evaluating tolerability during that time, right? So we're just making sure that there's no major side effects, and that they're tolerating it. And that's kind of really all we're looking for, not really benefit at that point. And so, but by the time we get to week 4, week 5, we're hoping to see a hint of something positive. And if we do, or earlier than that, sometimes we see it earlier than that, that's usually a pretty good prognostic sign that there is more good to come. So try to keep their spirits up by saying, listen, these first few weeks are not about it working. We're just making sure that you are a good fit for the medicine in regards to side effects. That's all. Making sure that we're not causing any problems. And what else did you ask here? And I'm a big fan of not talking about these sort of things over email or portal chat or text. I think these are too complicated for that. And I think also for medical legal reasons, you just want to have these conversations over the phone. You're going to get a lot more information. You're going to be able to ask a lot of questions. I find myself not being able to get a sufficient description of what's going on, or to be able to sufficiently and appropriately give guidance over text. So much is lost. So I think a phone call. In psych, we often will actually make an appointment, but I realize that's not necessarily pragmatic for every specialty. And so, maybe a 10-minute phone call just to check in and titrate the dose, and make sure that they're tolerating it okay, would be fine at week 2. You probably want to see them again, at least at week 4, though, in person, and, see them and actually kind of be able to evaluate their body language and, their affect, do a sort of a rudimentary mental status exam, right? That's going to tell you a lot, just the vibe in the room, right? And so I think it is important to see them in person, at least for that visit. And then probably if you're worried that they're not responding, you might want to see them again in person and not necessarily do that over the phone, but you could. And in determining that this is not going to work out, that this is a failed trial, and that we can either give it one more shot, which is kind of the recommendation typically, although not required. And you'll give them their options and kind of make a decision from there. Scenario 2. So this is about SSRIs and their side effect profile, which they have a pretty favorable side effect profile. That's where they're developed. They are safe, as opposed to their precursors, which are still safe, but not safe in certain situations. So like, for instance, TCAs were kind of classic for a while, tricyclic acid, nortriptyline, amitriptyline, just as effective in treating most of these conditions, a little bit more, well, just a different side effect profile, we'll say. But the big thing was that, they are extraordinarily lethal with overdose. And when we're treating people that are depressed, overdose is a particular risk. So patients that have a predisposition for or extreme risk for suicidality, we probably give pause to the idea of giving a TCA. You could on the contrary, although this is still very serious, overdosing on a whole bottle of Prozac is not likely to be lethal. And so that's an advantage of SSRIs. Obviously still a very serious clinical implication of that happening. But at least it's safer in that regard to the lethality of the attempt. And so SSRIs are preferable in that very particular situation, but also they just have a completely different side effect profile as well. That's usually perhaps a little bit more preferable to the general population. And those are, mild sedation, if any, mild weight gain issues with most of them. And we can get into this a little bit further. Sexual side effects are really the major culprit here, that will turn people off. And so some people, like I was saying sort of in the earlier slide about this scenario, some people hear that and they will not sign up for it they won't even give it a shot, right? They don't want to chance any sort of compromise to their libido or their ability to have an orgasm or an erection, anything sexual, that's off the table. So that's fine. And we'll skip over the class entirely. We should, sort of give them a little bit of a caveat, like, if you do start the SSRI and you have some mild sexual dysfunction, which is possible, we do have some mitigating drugs and solutions that we can fix it with usually. And so for instance, we'll go with sexual side effects here. 40 to 60% of the patients. So it's a big deal. It's a relatively pervasive side effect with SSRIs in various degrees. It's not always that significant. I would say anorgasmia is quite common. We actually use that to our advantage with premature ejaculation, right? So if somebody has that, we'll give them a splash of Prozac or something like that, and they will not ejaculate as quickly, and that's a treatment for that. That's a little bit of a segue. So low libido, anorgasmia, delayed ejaculation, ED, these are common sexual side effects for SSRIs. The worst culprit, which I think you'll find is going to continually be a repeat offender here, is Paxil, which is why I almost never pick it. That will cause the most sexual side effects. If the patient just has ED on an SSRI, we should have a low threshold for giving them some relief and prescribing Viagra, as long as it's not contraindicated by some medical problem. And primary care doctor is going to be perfectly positioned to decide if that's appropriate or not. And that's relatively easy to fix, right? And not really that big of a deal. If there's other sexual side effects like delayed ejaculation, or libido, anorgasmia, we have some other options to consider. We can add Remeron, mirtazapine. I've used exclusively brand names of these drugs in here. I'm not being paid. The mitigating drug for that, so Remeron, mirtazapine, you can add a small dose of that. You can even go up to as high as like, kind of more closer to the ceiling dose of Remeron if you want. You do need to be mindful of the fact that you might, if you're bringing up to 45 and you're on the high dose of an SSRI already, that's a lot of antidepressant. So, watch out for serotonin syndrome and side effects in general, because you're really hitting them hard with neurotransmitter modulation there if you're putting basically 2 fully therapeutic doses on. So I usually just use 15. I'm going to use Remeron as a mitigating factor for sexual side effects on an SSRI. Also, Remeron has a bad reputation for weight gain and heavy sedation. I don't think it's as bad as the rap that it gets, but it's there, and notably it is worse, sort of in a paradoxical way, at the lower doses. So we usually think of drugs as having more side effects at higher doses, at least in regards to weight gain and appetite induction. Remeron is worse with the lower doses. So if you have somebody, it actually comes in 7.5 milligram tabs as well, and that is intolerable to most patients. So if you're ever going to start somebody on mirtazapine, which we actually will talk about later, don't do 7.5. That will turn them off from the medicine. Another mitigating drug for sexual side effects is Wellbutrin. We don't necessarily need to use a full-throated dose of that. There's 3 different formulations of Wellbutrin. There's the immediate release, which is 3 times a day. There's the SR, the sustained release, which is 2 times a day. And then there's the XL, which is once a day. When it comes to using this drug for mitigating sexual side effects, it's pretty effective, probably not needing the XL. You can almost use it in a targeted fashion, like maybe a few hours before anticipated sex, almost like a Viagra, but or you might find that it's just best to put them on SR, right, a low dose, and dose it twice a day and just kind of have it be scheduled. I think there's a little bit of room to play around with that and trial and error it and see what works best. Obviously, if you can get away with the lowest dose, that's always the best route to go. So don't give Wellbutrin to people that can have seizures. Always think about that. Weight gain, again, Paxil, worst culprit, Zoloft, a fairly distant second, but still second. And Prozac is actually associated with weight loss, so that's kind of attractive to some patients. More common side effects here: GI distress, dry mouth, headache. So usually these are mild and time limited. They usually are just at the beginning of treatment and they go away. If they're kind of bad, you can treat them symptomatically for a few days because it's not going to be a long-term problem. You can give them a little Zofran for nausea, Imodium, Tylenol for headache, whatever, right? It'll go away. If it doesn't, then you need to abort mission, but that's pretty rare. These are usually not chronic side effects, as opposed to the sexual side effects, which will usually be there unless you treat them. They can have some activating effects, like almost this sort of akathisia-like restlessness and anxiety. So, Prozac is the worst for that, but, I still give Prozac to people that have anxiety disorders. It works well. There's just a chance that it may not sit well with them and it might make their anxiety worse, but I'll find that out within the first few days. And if that's not the reaction they're having, then Prozac's a perfectly great drug for treating anxiety. But it does come with this risk of possibly making your anxiety worse, at least initially, while they're naive to the drug and still acclimating. So if you're really worried about that and the patient's already on the fence about starting anything, don't risk it. Don't choose Prozac. Don't, pick something that is the least likely to be activating which would be something like probably like Zoloft. Not, I would say Paxil, but I hate Paxil, so which we'll get into later. But so Zoloft here you can see is in regards to sedation, right? So obviously not an activating drug usually. Everybody's a little different, so you know any of these can kind of happen with any of them, but these are just kind of the predispositions that are most common. So sedation most likely to happen in Paxil, and Zoloft is also a culprit there, but not, again, a distant second. Do you ever, I have a question here, do you ever add a short-term dosage of hydroxyzine to increase anxiety, possibly with, yeah, so that's a great strategy. I almost never start two drugs at once, because if there's a problem, I don't, you know, it's kind of confounded and I don't know what's what, but I will often do that. Whether that's with Klonopin or with hydroxyzine, like with particularly what we're talking about here is anxiety disorders, right? So it's going to take 4 to 6 weeks probably, right, for this antidepressant, whether it's an SSRI or whatever, to work for the panic disorder or the generalized anxiety disorder. So that's a lot of time for them to suffer, right? Until they get relief, and we don't even know that the medicine is going to work. So I will often put them on Klonopin or hydroxyzine to give them immediate relief and buy us some time while that therapeutic effect of the antidepressant takes effect, which can take, you know, a month, over a month, right? And then the idea is that, you know, once you get the antidepressant to a therapeutic dose and there's been enough time frame for it to work, that Klonopin will be rendered irrelevant and it'll be easy to come off of. And I always make it very clear, you know, this is a temporary solution. You're not going to be on this forever. I'm not going to let you get addicted to it, right? You usually can get away with fairly low doses. And, you know, if the antidepressant is effective, if and when, right, all of a sudden, you know, it'll be easy to come off of it. And you're not going to get major dependence or physiological or psychological on it, especially if you sort of prime the patient with, we're not going to be on this forever. Okay, this is just a stopgap until we get until the antidepressant starts to work. So yes, I absolutely do that. It's one of the few situations where I'll start two medicines at once, mostly because Klonopin is very clean, and I don't, if there is a problem, it's probably the SSRI and it's not the Klonopin. I'm not confused. And so that's a good strategy to consider to give your patient relief, because it's a long time for them to wait, especially if they're having panic attacks, right? You want to mitigate those immediately. And you know, it's a lot of docs are tempted to do PRN, benzo or hydroxyzine, and that's fine. But if it's like panic disorder, or if it's really generalized anxiety disorder that's quite severe and it's pervasive throughout the day, you really should just probably bring it to scheduled, you know, 0.5 Q12 and just cover the whole day. And that's Klonopin we're talking about. That is kind of the go-to. Valium's fine. The other ones are just too short. They're not going to cover the whole day. And so, you know, you will just it's better to preempt a panic attack and get ahead of it than to chase it with a benzo or hydroxyzine after it's already developed, because panic attacks don't last that long. And so by the time your benzo kicks in, it's already over with anyway. So we might as well just get ahead of it, right? And take it scheduled every morning at when they wake up. And then again, you know, what, 7 p.m. or something like that. And then they're covered. And it buys us time and gives them relief until that medicine can start to work. And then we can get off of benzo as soon as possible. So that's always a good, and really being in that state of mind for the patient is going to be psychologically, you know, sort of a good vantage point to increase the chances of your antidepressant working. Because if they're being kind of almost mini traumatized for 4 to 6 weeks while your Zoloft is trying to work, that's not exactly a very advantageous mindset for the patient to be experiencing. remission with the Zoloft, it might actually work against it or be an impediment to a therapeutic effect. So we really want to get them in a good spot, and then that's going to make it more fertile territory for a good effect with Prozac. Okay, so scenarios 3 and 4, this is benefits of two birds, one stone. If there's an opportunity to knock out multiple symptoms or disorders with one medication, go for it. So the advantage of this is it avoids polypharmacy, drug-to-drug interactions, increases the chances of achieving relief for multiple symptoms or conditions in an efficient and timely manner. It's a simpler regimen. It's better adherence. There's more patient buy-in, better patient, it's more easy to take, right? And remember, and there, maybe it's lower cost as well, right? It's just one medicine. So here's a good example of where we would do the two birds, one stone situation, right? Where we would just immediately skip over the SSRI class because the particular presentation is just begging for mirtazapine in this instance. So example would be, patient with major depression, presents with low appetite, anxiety, difficulty falling asleep or staying asleep, whatever, weight loss. Maybe this is a melancholic depression, right? And so we're going to use Remeron's side effect profile to our advantage, which is a huge advantage because it's a very sedating drug and it increases your appetite. And that is exactly what the symptoms of this particular depression are presenting as, right? So we are going, and the good news is that we don't even have to wait for Remeron to take its therapeutic effect as an antidepressant for those benefits to take place. That's on day one. They're going to get sleep fixed on day one because it's sedating, and they're going to have an appetite within a day or two as well. And, some patients are a little skittish and doctors are a little skittish with this one. Again, I think it has an unfair stigma attached to it. For weight gain. The way the weight gain happens here, it is not some mysterious thing. It doesn't, disrupt or derange your metabolic cascade. It just makes you hungrier. So you're only going to gain weight if you eat more. Now, that can still be a challenge, obviously, but if you are aware of that and you counsel your patient and you sort of preemptively plan for it, maybe they get the munchies at night, so they eat celery or something like that. Something healthy, and then they are satiated, and it's not a lot of calorie intake, and it's fine. The other thing to keep in mind is that these side effects are, even though they're to our advantage, they are particularly worse in the beginning for two reasons. They're naive to the drug, so they have time to acclimate. So the side effects will get better just as more time on it. The other one is that it has sort of this paradoxical inverse relationship. I think, as I alluded to before, 15 milligrams is particularly sedating and appetite inducing. As you get to 30 and 45, it has sort of an inverse relationship with those. And we are at a less sedating and less appetite inducing situation with Remeron. It's also been shown to have a therapeutic effect in regards to its anti-anxiety coverage as soon as week 2. So it also just works faster with some of these conditions as well. So this patient, I would put on mirtazapine immediately without even considering an SSRI because they're going to get relief from some of their major depression symptoms right away with this medicine. It's going to work to our advantage. So it's the appetite and the sedation are not a problem. They are a feature, not a bug with that one. Another little deep dive on mirtazapine. I know we're going to run a little bit out of time here. So very sedating. I think we talked about this already. Inverse relationship with the dosage. This is kind of a typical Remeron trial here. You can go pretty fast with it, especially if they're finding the lower doses intolerable. Try to ask them to persevere. It's going to get better. If you're not noticing any improvement by 4 to 6 weeks, it's maybe not going to go anywhere because, like I said, this is usually a little bit of a faster actor in regards to it working. Scenario 4, two birds, one stone. So this is another two birds, one stone, but it's different. It's not symptoms, it's conditions, right? Which is maybe even more significant. So we have sometimes we have two different conditions that will be treated by the same medicine, right? And so, for instance, depression and comorbid ADHD. And if we can avoid stimulants, especially in this day and age, that's always kind of a perk. So, um, so for patients experiencing depression with ADHD, you might consider Wellbutrin, which is not an SSRI. It's a dopamine norepinephrine reuptake inhibitor, and it has been shown in studies to be an effective treatment not only for depression, which is very effective for, but also ADHD. Again, not for patients with seizures. And an important side note on Wellbutrin, it is one of the few antidepressants that does not double as anti-anxiety too. I mean, most of these, right? Most of these antidepressants, Remeron, Effexor, the SSRIs, they treat GAD, anxiety, and depression. Just, you know, they're all fine. Wellbutrin does not treat anxiety. It is a strict antidepressant in the strictest sense of the word. It will actually perhaps make anxiety worse because it's a little activating. So you give it in the morning, okay? And it's got great weight gain and sexual side effect profile too. So that's also something to kind of keep in mind. For anxiety and fibromyalgia, another example of two conditions where you can treat it with one drug, ideally. It's been shown that, and this is also true for depression and anxiety as well, that an SNRI, particularly Cymbalta, has been shown to be effective for not only fibromyalgia, but of course also anxiety and depression. It can be a bit of a, Cymbalta can be a bit of an activating medication. So, you know, starts low and goes slow, especially if anxiety is the disorder you're trying to treat, right? Because you don't want to risk them having a bad taste in their mouth about it unnecessarily. So give it a fair shot. You need to be mindful that it can cause elevated blood pressure. So that's not something you probably want to maybe sign up for if they already have that. And you want to monitor for the development of it afterwards. These are basically kind of like SSRIs plus. They're just a little bit more robust. So they have a very similar side effect profile. So again, very commonly having sexual side effects. Cymbalta is a little hepatotoxic, you know, not something I've ever really seen too frequently, but it's good practice to make sure their liver is fine. Or if you know that they have liver disease, that's probably not the direction you want to go. And these two are just notorious for being difficult to come off of. Effexor and Cymbalta. I would say Effexor is probably a little bit worse. And I mean discontinuation syndrome, which we'll get into quickly here. But when it's time to come off of these, right? It's a little hard. They're gonna often withdraw from it and have this discontinuation syndrome. And so you got to get a little bit creative sometimes with how you wean them off these medicines. A lot of brain zaps are common with trying to come off of these. And so it's definitely a little bit of a challenge. I've got some options for you here. Quick overview with DC syndrome. SSRIs, SNRIs, it's more likely to happen for patients that have been on the drug for, whether it's either of those, for a longer, you know, so I've had a patient that was on it for 10 years. It's very hard to get him off of his Cymbalta. We had to go to a compounding pharmacy, which is a bit of a hack here, to make, you know, the lowest dose of the pill for Effexor is 37.5, at least Effexor extended release. So when you get to that dose and you try to go to zero and you get discontinuation syndrome, what do? There's no smaller dose, right? And it's not something you can split. So you go to a compounding pharmacy and you have them make custom incremental dosed pills. And then you have a little bit of an easier stepwise fashion to get them off of it. Classic symptoms of discontinuation syndrome are, you know, flu-like symptoms, malaise, headache, insomnia, dizziness, fatigue, myalgias, brain zaps, all that sort of stuff. It's very uncomfortable. The nice, you know, something to keep in mind, the good news is it's extraordinarily and expediently treated with just taking more of the medicine, which is a little bit of a backtrack, but it makes the discontinuations syndrome symptoms go away within an hour-ish, right? So if they have that and they're like, wow, this is awful, just have them take another dose of their Cymbalta and it'll go away. It's not a permanent solution, but it'll give them temporary relief until you figure out a new, perhaps more gradual taper with them. Obviously, the other sort of risk factors for discontinuation syndrome is are the meds that are the shortest half-life, right? Again, Paxil. I don't know why anybody's on Paxil anymore. Another little bit of a hack here is that, and this is a little bit more extravagant, but works great. You can, so if you're on Paxil, right, and you're trying to well, let's say if somebody comes to you on Paxil because you didn't put them on it, and they're trying to come off of it, and you get them a low dose and you go to 0, you try to split it, whatever. It's just, they're having discontinuation syndrome. These SSRIs and also SNRIs have a similar enough mechanism of action that they have a lot of crossover. So Prozac has an extraordinarily long half-life. So what you'll often do, and sometimes you just go down this route from the get-go, especially with Paxil, is you just stop their Paxil and immediately replace it with sort of a commensurate dose of Prozac, right? And then you start the taper from there. And it's so much easier because Prozac has a long half-life. It almost self-tapers, actually. So, let's say they're on, what's what I have here? Effects, or wait. What's an Paxil 40, right? So they're on Paxil 40. So you put them on Prozac 30. That's roughly an equivalent. And then you do the taper from there. You do Prozac 20 for a week, Prozac 10 for 2 weeks, and then you stop, something like that. And then you can just go from one to the other without any cross taper. And you can also usually pull this off with Effexor and Cymbalta too, although it's a little less coverage, but often, especially if you're struggling, it's worth a shot. Scenario 5, family history. Let's skip over this, but basically, bottom line, this is when your family history strongly suggests that SSRIs don't work, or that a particularly different class does work. And so maybe that informs your decision. There's not a lot of research here to back this up, but there's not a lot of research to say it's not true either. I mean, your response to an SSRI is very much influenced by your genetic makeup. So there's a lot of reason to think that there's some factor with this, right? And so with the closer the relative, your identical twin is going to be your best sort of case in regards to genetic responses. But I wouldn't, this is definitely the weakest one to skip SSRIs, but it's something to think about especially when you're taking a shot in the dark. This might be something to go off of, because there's not always an obvious indication which one to pick. This is a little more about that. This is a case. We'll quickly go through this. 23-year-old. This is a partial response. This is important. 23-year-old female grad student, no previous history of psychiatric stuff, goes to see their primary care doctor. Classic, symptoms: dysphoria, anhedonia, low energy, high appetite, some gained weight, right? The depression began about a couple weeks ago. Trouble staying asleep. Bottom line here is, the primary care doctor establishes a diagnosis of major depressive disorder. There's nothing safety going on. She's not suicidal or anything like that. He starts her on Lexapro, gives her all the risk benefits alternatives, and gets informed consent, right? Recommends maybe psychotherapy, checks in with her in a week, maybe over the phone. And she's tolerating it well. There's no benefit, which is no surprise, which we sort of coach the patient on, so they're not expecting anything, right? We're just checking to make sure they're tolerating it. She's tolerating. She's got some mild GI distress. She took some Pepto. It's fine. We bring her up to 20, right? We're going to get where we're going. Now we're at the therapeutic dose. That's the nice thing about Lexapro. It's a 1-2 punch. We're there. Then we give her some time to sit there on that dose. Check in with her on 4 weeks. Some improvement. definitely some progress to be desired still, but it's early on. We're only at 4 weeks. We're seeing some encouraging signs, so we keep going, right? Give it some more time. We don't push the dose. Now we've gotten to 8 weeks, and it's plateaued, and it's gotten plenty of time. And since we've seen it and we really don't want to get rid of that, we want to preserve those benefits, the primary care doctor maybe pushes the envelope on the dose and brings it to 30 to see if we can squeeze more benefit out of it. And you might, right? There's still problematic symptoms. We don't, it's not a stopping point. It's only a partial response. So despite, so we give it to 10 weeks at, 2 weeks at 30. Bupkis, nothing. We're stuck with just this partial response to Lexapro, right? So now what? So, we don't want to we're kind of in between a rock and a hard place. We don't want to get rid of that benefit, right? But we also don't want to stay here. So what do? Well, here is a very common thing we do is that we will go ahead and keep that Lexapro on board. We'll probably bring it back down to 20, since 30 didn't do anything and actually made the sexual side effect a little bit worse. And then we'll add an augmenting agent. What is that? Well, it's often another antidepressant from a different class that works with a different mechanism of action. So the idea here is that we have this sort of strategic intermingling of 2 different mechanism of actions that just is the right sweet spot for your patient, right? And it's a little trial and error, but there's some direction to maybe pick it, so again, you try to use the side effect profile to your advantage strategically, right? So this patient has sedation, concentration problems, weight gain. So my augmenting agent is probably going to be maybe one that has a different mechanism of action, right? Different class, but is good for those types of remaining lingering symptoms that the Lexapro just couldn't do it, right? Couldn't hack it. So which one is that? Well, it's Wellbutrin, or at least that it could be. Wellbutrin is activating, so her energy problem maybe is not, at least not going to get exacerbated with that. It's got a great weight gain side effect profile, right? So maybe that'll at least not exacerbate it, maybe fix it. And she's got a little bit of a sexual side effect on the Lexapro, and the Wellbutrin is going to hopefully knock that out too. So in addition to the nice intermingling of these 2 drugs that might end up getting her across the finish line in regards to remission, it also is going to definitely not make her remaining lingering symptoms of depression worse, and maybe treat them, right? You just purely out of the side effect profile, if not because they're a good combo. And it might even solve the side effect, right, with the Lexapro. Now, obviously, when you do this, you don't do, you don't do full therapeutic doses on both, but you usually use one as your primary agent at the full therapeutic dose, and then just sort of a splash of another one. So for here, Lexapro is going to do the legwork at 20, and you might do, Wellbutrin XL 150, all right? And that's your combo. You don't want to bring that up to like 300 or 450. That's a lot. That's too much of both. Would you consider, I have a question here, would you consider augmenting Wellbutrin as long as no seizure disorder? Well, as the primary agent or as the augmenting agent? Bottom line is I would, if it was the primary agent, I would augment Wellbutrin if it was only giving me a partial response. If it's the augmenting agent, as we've just seen, yes, I use that as an augmenting agent too, as long as there's no seizure disorder. You're right. Or eating disorders or anything like that, right? Because the electrolyte imbalances and seizures and all that sort of stuff, right? So no contraindications to them. Oh, okay. I figured that. Yeah, I might have answered your question premature. Okay. So any other questions? Thanks so much. I'm sorry I went a little bit over.